So our next speaker is Dr. Puneet Arora, a good friend, and it's my pleasure to invite her for a talk here. She's founder and director at SIFAR, Gurgaon. She's executive member Indian Fertility Society and a founder member of Fertility Preservation Society. Medical advisor to many cancer survivorship projects, CanKids. She's advisor to Late Effects Committee of Indian Cancer Society, executive member and fertility advisor at TVCA in India. She has received many awards. She is a section editor, peer reviewer, and has many publications. Her interests are primary, secondary, tertiary care provider for all aspects of infertility, with special interest in recurrent implantation failure and low prognosis patients. Dr. Puneet Rana, please enlighten us with your talk.
Thank you. Thank you so much, Nisha. Yes, indeed, a good friend. Thank you very much for your kind introduction. So I think I can only share if Mohit stops sharing.
Mohit, please stop sharing.
Are my slides visible?
Yes, yes.
Okay. Thank you, Nisha. Thank you to the whole team, the whole organizers, Dr. Pankaj Talwar sir. I can see Meenu, Nisha, for having me here. So I have been given a talk. I know we have been hearing a lot of genetics, and it has been quite an eye-opener for me also. I think I have learned a lot since morning. So I've been asked to present on hereditary breast and ovarian cancers. So what exactly they are? So it's a syndrome basically. It's a syndrome where there is a predisposition to cancer, in which individuals are at greater risk of developing certain cancers, but mainly breast and ovarian. So what can be the causes of this hereditary breast and ovarian cancers? It is, as the name indicates, hereditary. It's an inherited genetic condition. It is caused by variation in a single major cancer-causing gene, which is the breast cancer susceptibility gene 1 and the breast cancer susceptibility gene 2. Basically, the BRCA1 and BRCA2, they are commonly known as, they are tumor suppressor genes. These genes do help to regulate cell growth. So when these genes are altered, cells multiply in a very haywire way and a weird way. And we all know this is what cancer is. Cancer is altered division of a group of cells. So a mutation in these cell line increases a woman's lifetime risk of breast and ovarian cancer. Not only women, I would say men also, as I will discuss in my subsequent slides. So men with these mutations also have increased risk of breast and prostate cancers. So it is an autosomal dominant pattern inheritance. It has with a 50% chance of inheriting the mutation from the affected parent. So if we look at these two, BRCA1, BRCA2, they are mainly responsible for inheriting breast and ovarian cancers. Breast cancer, if we see BRCA1, it increases the likelihood of development of cancer to 50 to 65%, and in males to 1.2%. The BRCA2, 40 to 55%, and with males up to 9%. Ovarian cancer risk increases by 40 to 65% with BRCA1 and 15 to 25% with BRCA2. Not only this, pancreas cancer, prostate cancer also show an increased incidence with such mutations. When we say ovarian cancer, they're not only cancers confined to ovaries, but also to the cancer of fallopian tubes and primary peritoneal cancers, can also be linked to altered BRCA gene mutation. And among the other cancers, like I already said, pancreas and prostate, but there is also a little discussion about melanoma, cervical, and uterine cancers happening with such mutation. So if we look at the study, the pink graph is for the BRCA mutation, the gray is for the general population. We say that the individuals who are carrying the BRCA mutation, breast cancer by the age of 50, 70, a relapse of breast cancer or a second type of breast cancer, and an ovarian cancer risk is increased to the baseline population. So what is the inheritance of it? So the gene variation, obviously, in this mutation in hereditary breast ovarian cancer is called as germline. It's basically a germline mutation as opposed to a sporadic mutation. I know we have heard this in the morning, but just to recap, So we all know germline mutation is basically a mutation being carried by an egg or a sperm. So it happens before the fertilization. But sporadic mutation is basically, or a de novo mutation happens after the fertilization. So these BRCA mutations have been shown to be the germline mutations. And as you can see in this diagram, the mutations here may be the egg cell. This leads to mutation in a particular part of the body, not all cells. If it is if it's a somatic mutation or a sporadic mutation, if it is a germline mutation, it is carried before every kind of a cell gets affected, and mainly it can affect the whole system also, many organs of the body. And if we look at this pedigree chart, so basically it's indicating what we called as a germline mutation because it is present in the egg beforehand, before the fertilization process. So if we look at the genetics of this cancer, it can be not all mutations lead to abnormalities, not all mutations lead to cancer, but a certain variant of this mutation, what we called as can be a pathogenic variant. And the ones which are carrying the mutation but not causing disease are also a subgroup. So they may not show now, but their offsprings may show it. So this is a very complex, I would say, understanding. So if you look at this study, among the populations, there was a wild type mutation in 508, 67%, 23% had the pathogenic variant, and 10% there was a mutation, but of unknown significance. And in those unknown significance, around 37%, nearly equal among the BRCA1 and BRCA2. But cases where there was a pathogenic variant mutation, it was mainly the BRCA1 which was found rather than the BRCA2. So prevalence and affected population. Like I said, it can affect both men and women. It can occur in any population. It can happen to any ethnic or racial backgrounds. It is, in fact, the most common cause of hereditary breast and ovarian cancers in all, irrespective of ethnic and racial backgrounds. The prevalence is between 1 in 200 to 1 in 800. But there's certain subgroup of individual like Ashkenazi Jewish population, which have shown a relatively higher incidence of these mutations. Like what we say, the African population has more incidence of getting fibroids and all. It's the same way that this particular population has a relatively 1 in 40 incidence of developing or inheriting the mutations in the BRCA1 and BRCA2 genes. So the underlying cause of cancer, obviously, it's not completely understood because, like I said, the certain individuals do carry these genes, but they do not harbor the cancer. So certainly there are some lifestyle factors which add on to these mutations and cause cancer. Now, whether it is the environmental factors, whether it's smoking, or maybe it's an additional genetic disorder which hasn't been studied yet, maybe variation in other genes. Obviously, that's the research area which are responsible that these subgroup of people who have unknown significance, they don't develop cancer, but some subgroup who develop cancer have a higher incidence. So I think it is also beyond that complexity of just finding the mutation. What we need to know is basically the history. The detailed genetic history of a patient is also very important when we have to give a risk of developing these hereditary and breast ovarian cancers, obviously along with the lifestyle factors. So why do we need to know about it? Because we know that there is definitely a increased risk of breast cancer, increased risk of ovarian cancer. And if we know more about it, we can offer additional cancer screening programs. We can talk about medications, or I have got a further one slide of what we called as a chemo prevention thing, which we discuss with our patients. And we can also do preventive surgeries of breast or ovarian in case patient wishes to. So it helps us to counsel our patients better and offer them any additional cancer screening programs if available. So how do these patients manifest? Like I said, the first and foremost is maybe if we are screening it's a known case, I think it's easy that we get it done. But if it is not a known case and where we have to request the BRCA gene testing, whom should we get it tested? So anybody who's got a breast cancer at a younger age group, maybe less than 45 years of age, or with the breast cancer, which is triple negative. Any breast cancer in men, irrespective of the histopathology type, irrespective of the grading, I think they all should be tested. Anybody with ovarian cancer, fallopian tube cancer, of the primary peritoneal cancer. Bilateral cancers also increase the chances of testing positive for BRCA mutations. Pancreatic or prostate cancer with a Gleason score of more than 7. Pancreatic, prostate cancer in multiple blood relatives. Ashkenazi Jewish population, like I just said, they are at higher incidence of getting the mutation, which is 1 in 40. And obviously a known BRCA mutation. I think that's the most simplest group, because if it's a known, we tend to kind of get it done now routinely. But it's the group where we have to select that maybe they are at risk of harboring that mutation and hence leading to further breast, ovarian, or pancreatic or prostate cancer. How can we test it? How can we do the testing of BRCA1, BRCA2? I will not go in much in detail, but just we need a molecular genetic testing, and obviously from a good lab. It can be done from blood. I don't know whether somebody can correct me. Saliva samples are not being done here yet, but blood is the routine testing. We have to be very careful of the lab we choose, because they should be accredited genetic testing labs, who also should have I would say, a genetic counselor, not only the clinical counseling, because the genetic counseling also plays a very important role in such cases. And because it's important that in case patient has got a high risk history, but shows negative for BRCA1, BRCA2, they can still develop some form of cancer. So hence the counseling is very important. Obviously, we can also look for symptoms of breast cancer, whether there is any lump, or thickening of breast tissue, change in breast size. I know we have a lot of awareness programs where we try to find out, highlight these symptoms. If there's any dimpling, peeling, redness, nipple discharge, or anything which can give us a clue that there could be a chance of breast cancer. So yes, health history, physical exam, further investigations like mammography, biopsy, FNAC will help us. These are definitely important, besides doing the genetic screening and genetic testing for such cancer. Hormone and HER2 status testing is important. X-ray of bone scans are important to see if there is any advancement or any invasion in the or there's any spread of such cancer in the nearby organs. Ovarian cancer, a little bit vague symptoms it presents with. It can present with a vaginal bleeding or abnormal vaginal discharge, pain or pressure in the pelvic area, abdominal or back pain, bloating sensation, difficulty eating, changing in the bathroom habits like urgency to urinate. So little vague symptoms they present with. That's why a lot of ovarian cancers are diagnosed quite late in their progression. We can do transvaginal ultrasound. We can do some blood work, which is CA125. But all these do come with the limitations because they're not specific for ovarian cancer. They're very non-specific markers. And hence, it's important that if there is a strong history, besides this, it is important to get the genetic mutation tested as well. How can we manage it? Like I said, that it's easy to order test and write a test, but when it comes to counseling, that is the mainstay of such syndromes if anybody's harboring, because it's not only about testing positive, but what are the next steps? What are the implications to their offsprings? What are the implications of their survivorship in case they get the cancer? So genetic counseling is very, very important, comprehending those medical facts, understanding how hereditary contributes to disorder, understanding the alternatives for dealing with the risk of recurrence, choosing a course of action, and making the best possible adjustment. Obviously, communicating the risk, especially in patients who test negative, and also offering them pre-genetic testings or pre-PGT testing in case they are planning a pregnancy, if they are positive with the BRCA mutation, like Dr. Gauri ma'am said that PGT can be done nowadays very safely, checking for BRCA1, BRCA2 mutations. Obviously, we need a detailed analysis of the affected individuals before we can check in the embryo. So all these risks need a communication from a genetic counselor and from a clinician. We can offer them as a clinical, these are a little more clinical slides. What we can offer them, we can offer them prophylactic mastectomy if it has been diagnosed on one's breast, and if they're positive for BRCA mutations, the contralateral prophylactic mastectomy is something which can be offered. The surgery involves maybe one or both breasts, but that can be offered. Decision making has to be a joint discussion with the healthcare provider, with the genetic counselor, and the aim is basically risk reduction for the future. For the ovaries, yes, risk-reducing bilateral salpingo-oophorectomy is something which can be offered. It's a preventive surgery recommended for individuals at high risk of ovarian cancer. Its recommendations are very similar to those who have been tested positive, and without a personal history, because we don't know what exactly the advancement or the progression of it if there is no family history. So such patients do get worried more than the patients in which the BRCA gene mutation run in the families. So obviously we need larger studies, but this is something which should be discussed with the patients when we talk about the BRCA mutations. So advanced ovarian cancer with BRCA mutation. Now this is a big debate that when there is an advanced ovarian cancer with BRCA mutation, should you offer bilateral mastectomy or should you offer bilateral oophorectomy? Because over here, we have to look at the 5-year survival rate. The decision is based on the high risk of death in such cases. So we have to be very careful, and that's why a detailed counseling is important in such cases. Therapies in such patients, we all know that there can be a chemotherapy, there can be a targeted therapy, and there can be immunotherapy. Now, targeted therapies are the mainstay of treatment because they are not kind of acting on the cells, but they are blocking the growth of the cancer cells. And that's very important, and because they're not targeting on the normal cancer cells, and hence the side effects of such treatment are important. And in BRCA mutations, it is mainly the PARP-based regimens which have been quite useful in such cases, because what happens is, if you look at this beautiful diagram, so this is what happens in a cancer cell. There is alteration in the genetic architecture, maybe there's a DNA damage. And what PARP does is, which is poly-ADP ribose, it tries to repair this break. And obviously, it is doing the repairing in the cancer cells, which we don't want. So these all medications, targeted medications, are basically PARP inhibitors, where the PARP doesn't do the repair, and then there's a complete breakdown in the cell and leads to cell death. So this is the basis of kind of providing medical treatment in patients with hereditary cancers, because we know that there is some genetic breakage in the genetic architecture, and hence these targeted therapies are really helpful. So basically all these medications which are given in such patients are PARP inhibitors, olaparib, niraparib, rucaparib. So they are inhibiting the PARP so that they don't repair the abnormal gene breakage in the cancer cells, and hence leads to apoptosis of the cells. So medical implications, yes, they have all been kind of approved by US FDA for germline BRCA mutations and HER2 negative breast cancers who have been treated with chemotherapy in the past. So to prevent the recurrence, patients who don't want to undergo prophylactic mastectomies or oophorectomies can be offered this treatment. So because they are meant for such subgroup of patients. Like I said, these treatments are important advancements in the management of breast cancer. And this has only happened because of the better understanding of the genetics of this mutation. Because if we're not clear about the genetics, we will not be able to do any such advancements. So thanks to the genetics department that we are able to offer to such patients, targeted therapies to such patients. So olaparib, like I said, rucaparib are all kind of medications, agents which have been proved successful with a good recovery and 5-year survival rates. Chemo prevention, just a slide on that. When these therapies were not there, there was a concept of chemo prevention with tamoxifen, which lowers the risk of developing breast cancer. It still is useful, but obviously this is oncologist's choice whether to put them on the PARP inhibitors or the tamoxifen. So So just to conclude from what we have just seen in the last few slides, understanding of hereditary ovarian and breast cancer is important for patient counseling and also to offer further treatment interventions. Genetic testing plays a crucial role, and that's the mainstay of diagnosing in identifying individuals which are at high risk for breast and ovarian cancers due to BRCA mutations. Genetic counseling is helpful in helping patients understand their risk and make informed decisions about their health. Targeted therapies such as olaparib, ruca, and niraparib have shown effectiveness. These therapies do offer a new hope for our patients. Challenges remain, including the need for larger studies, no doubt. We as IVF specialists can help them, offer them genetic testing in the form of PGT to assess these mutations and kind of transfer the embryos which are BRCA free. So the integration of these testing, targeted therapies, the fertility management has helped us to understand it more, offer to our patients, and being able to give our patients a personalized medical approach, especially in a subgroup which are carrying BRCA mutation and associated cancers. And thank you so much for patient hearing.
Thank you so much, Puneet ma'am. It's been a wonderful lecture that you've delivered to us and made us understand the angle of genetics in hereditary breast and ovarian cancers. Now, I think since all of our speakers for this session have completed their talks, we can ask our delegates to ask their questions. I am hoping that we still have Gauri ma'am with us, Dr. Anuradha, Dr. Rajni, and
I think
Professor
Dr. Gauri ma'am has left, Dr. Meenu. She has some prior appointment. She is not there, but we can ask Dr. Yogesh, Dr. Anuradha, Dr. Puneet, and Dr. Gauri
Professor
ma'am has left.
B.P. Das, if he's there,
Yeah,
Dr.
yeah.
Anuradha,
So if there are
Rajni.
any questions. Dr. Anuradha, we have you.
Hello.
Yeah, we have Dr. Anuradha, we have you. Dr. Puneet, you are there?
Yes, I'm very much here, Nisha.
Okay, okay. I'll come to Dr. Anuradha.
I think Dr. Rajni is here as well. Maybe she can highlight a bit on the. Hi, Dr. Rajni. So pleasure to see you.
Hi, Dr. Puneet.
It was a pleasure hearing you.
Same here, Dr. Puneet. Thank you.
You can highlight a bit on the, I'm not much whether it's covered, on the PGT with the BRCA mutations and give your insights from as a genetics person. What do you think about it?
Yeah, Dr. Puneet, you rightly, when you gave your presentation, it was really beautiful. And as you highlighted the importance of counseling, I think it is one of the really important factor where counseling comes into picture, that before going forward for any testing, we have to explain all the prevalence, means how much is the risk associated. And we know that when we go for BRCA testing, it's important to understand that we have to have a family history. There are patients who are getting BRCA testing done without even family history because it is a kind of predictive testing. But we know that it should not be indicated. And also PGTM should not be indicated based on only a predictive testing when there is no family history. But if there is a family history, definitely we know that we have to explain the patient the risk associated and how much recurrence risk is there further, and also finding a positive variant in BRCA in embryos. We have to explain the patient that it is not necessary that the baby is going to be affected with breast cancer or ovarian cancer, because it can, over the time we know that you need 2 hits for cancer to occur. So it can be a possibility that baby can be completely normal also. But when the baby become adult, you can explain the person to go for a screening routinely on a monthly basis or like 6 months, so that they can we can have a kind of a screening priorly so that this is not going to occur.
Yeah. So I think we very much agree that, what you said, the family history, that is the main, indication, no doubt about it. But recently, like I highlighted, there are certain subgroup of patients like triple negative, receptor negative patients, or patients with diagnosed at a younger age. So they have also been shown. So I think it's all talking about the awareness. But at the same time, if we are testing it, we should also know that if it's a mutation being diagnosed as of unknown significance, that panic button should not come in, because that, I mean, living with that mutation risk, which is of unknown significance, can be quite mentally challenging for the patients as well.
Yes,
Dr.
and
Dr.
that's
Puneet,
where
I think you are absolutely right in that. The problem is that once you know, the panic button hits on its own. So I think the best thing to do is check only when indicated. And if not indicated, we should not check or not recommend. That's what I feel.
That is absolutely the correct way to go about it, ma'am. And if, of course, they have been discovered to have a BRCA mutation, then we have the screening methodology. So I think they should be have a heightened sense of going through that screening, and if required, the prophylactic surgeries. Those can be done for such affected families
Dr.
with
Meenu, we
positive
can
mutation.
declare lunch also simultaneously
Yes,
for
ma'am.
50
Yes,
minutes,
ma'am.
because
Let's close
sharp
it, ma'am.
start at
Yes, if there are no more questions, let's close it. And ma'am, we will all
we do have
aggregate
we
I
do
have
have
one
questions.
question.
We
I
do
have
have
one question.
questions. Somebody who wants to discuss, they can continue discussion. Other people can break for lunch. So because at sharp 1:30, we will restart.
1:30, we will get started again, ma'am. Sharp 1:30.
So Dr.
I
Rajni,
just
I also had a question. There was a question in the chat box also regarding the need for grandparents sample for PGTM.
Hi, my name is Nabil Arash. Today,
Yeah.
Sorry. So, Dr. Nisha, regarding this grandparent samples, as I said in the message that not every lab will ask you those samples. There are indications where we know that affected child is not there and we need to rule out the mutation in the family. And we are using a linkage analysis. Whenever the method of choice is haplotyping, it's always better as much sample you have, as much confidence you will have with the analysis. So I know there are a couple who always say that we cannot provide a sample, but we need to explain that what is why the request is there, and if they want a good accuracy rate and good confidence on the report, they need to provide the sample. But it is not. There are cases where it is not necessary also, and so counseling is what is done, pre-test counseling, where we know that we need to explain that what samples are required and why they are required.
Is it it is based on like the technique also, the different technique?
Yes.
Yes. It's based on technique also platform use, because there are labs who are using, as I said, strategy is like they do targeted testing and they do NGS based haplotyping also. Okay. And so whenever targeted testing is there can be an involvement of direct and indirect testing, where we always require that we should have a good informative marker in the testing. And finding fully informative marker, at least 2, is very important. So in case we are not getting, when we get only couple sample, we may not find an informative marker. So then it becomes a challenge to give a confident report to the couple. So that's how this will be defined by
मेरे रूम से कर दीजिए करने तो 10 मिनट आ रही है मैं वापस.
So if there are any questions, all our esteemed speakers are here. May I
Yes,
request
just
everyone?
additional point. Sometimes even the type of gene variant that we are testing also plays a role. I mean, which area of the gene is it? Is it in the GC-rich area? Is the amplification going to be okay? Is there a higher risk of allele dropout if we are doing PCR? So some of the technical causes of the nature of the variant itself could require more number of samples in the family, along with all the points that Dr. Rajni also mentioned, lack of proband and type of technology, etc.
Rightly said, Dr. Anuradha. Thank you so much.
Thank you.
So thank you to all our speakers, ma'am. You have enlightened us, and Professor B.C. Das, Anuradha ma'am, Dr. Gauri Devi ma'am, Dr. Rajni. We're so thankful to you. I think we'll break for lunch, ma'am, now, if we do not have
I think
anything
Dr.
else.
Puneet had one question. Dr. Puneet.
So I think my question is to Dr. Anuradha and Dr. Rajni. So, when patients ask about, getting a BRCA mutation, obviously we tell them about the genetic lab. So what are the other things they should look for? And what exactly, something they should look for, if we can guide them, that if the lab is offering this, then you should have the test from that lab. Something you want to highlight on that aspect?
So the most common and the most basic thing is whether the lab has a quality assurance program going on, So whether it's NABL or CAP or whatever, we need to have some quality program that should be running in the laboratory. The second, we need to have a good genetic counseling setup within the lab, which can explain, and have multiple sessions with the family pre-test and post-test to explain them the limitations and what the technique can do, what it can pick up, and things like that. And we should also look for expertise within the laboratory to be able to interpret the results properly. In the sense, should be able to not just talk about the genetic aspect of it, but also give a good clinical correlation, saying what could be the prognosis and things like that, so that they can take decisions based on that. And sometimes the patients ask for just BRCA testing because of family history. But then it is important for us to also inform them that BRCA has only a certain percentage of cases. BRCA is highly prevalent. But in many cases of breast and ovarian cancer, hereditary breast and ovarian cancer, we do have role of other genes also. So a panel of tests, genes can be tested to offer such, a comprehensive diagnosis of the risk that they have for hereditary breast and ovarian cancer. So if selection of lab purely, I think, could be on quality assurance and their clinical, motivation to give reports that are clinically applicable and understood, and a good genetic counseling facility. Dr. Rajni, if you would like to add, please go ahead and add a few more.
You're muted, Dr. Rajni.
Dr. Rajni, you have to unmute yourself.
Thank you, Dr. Anuradha. You have completely covered all the topics. So my advice is the same, that when we look forward for, as Dr. Puneet said, that definitely these days we have a lot of labs mushrooming, and the confidence level. So many times it's very important to understand how to choose a lab. So quality is always the first preference. Clinical knowledge is again second preference, and how good support you are getting on timely, that, and how convinced you are with the knowledge and with the quality. So, and you have to also understand that whether the testing labs, they are following proper guidelines based on the testing or not, because there are labs who offer a lot of testing which are not even guided. So irrelevant testings are also there. So we know we have to provide the testing only where it is guided properly. No unnecessary testing.
Thank you.
Thank you. Okay, Dr. Meenu, we can, I think, break for lunch for 15 minutes.
Right.
Sharp at 1:30, we'll start with
At 1:30. We congregate again, ma'am. Thank you, everyone.
Thank you. Thank you, Dr.
Thank
Nisha.
you. Wonderful
Thank
to have you all.